Okay, so this is chapter 7, the process of birth, labor and birth. Okay, it starts on page 187. Flip over to 188. These are some key words, of course, in the front of your chapter and some learning objectives, but you need to go by the learning objectives that's in your syllabus that you have or will get. Okay, so it's talking about the process and labor of birth. The 5 P's are here. Powers, passageway, passenger, passageway plus passenger, relationship, and psychosocial influences. Okay, so let's go down and talk about uterine contractions, the assessment of uterine contractions. Okay, so there are things called frequency, duration, and intensity. You need to know these terms, winks and lollipops. Okay. So the frequency of a contraction is measured from the beginning of one contraction to the beginning of the next contraction. So if you'll look over here, it shows you the frequency of contractions. And this is in your book on page 189. So the frequency starts here and it goes all the way to here. Okay? So the beginning of one contraction to the beginning of another contraction is called the frequency. The duration is the beginning of one contraction and the end of that same contraction. Okay, you need to know those terms. So frequency, the beginning of one to the beginning of another. Duration is the beginning of one to the end of that same one. And on labor strips that we'll view in class, you'll see there's 1 minute increments in the little red line. These are green, but it's the red lines on the strip. Okay. And there's the same picture on page 189. All right. So this picture that's on page 190 shows you the different anatomical figures of the bottom of the uterus. You have the amniotic sac, amniotic fluid around the fetus, the internal os of the cervix, the cavity of the cervix, and the external os. And this is where the nurses actually check the dilatation of the cervix. Okay, they check for effacement, which is how thick the cervix is, and then they check for the dilation or dilatation. Okay, they also check for the presenting part. How is it presented? Okay, so on page 191, box 7-2, there are landmarks. Okay, and we'll talk about this in class as well, demonstrating it. But the mentum is the fetal chin. The sinciput is the brow, like the eyebrow area. The bregma is the anterior fontanelle, which is up here on the top of the fetal head. Vertex is the area between the anterior and posterior fontanelles, which is here. The posterior fontanelle is here. And then the occiput is back here, the occipital bone. Okay? So if you feel the back of the head past or post posterior fontanelle, that is the occiput area. Okay? The fetal lie. How is the long axis of the fetus in a relationship with the long axis of the mother? So is the baby vertex, which is here, a longitudinal lie, or is it transverse, the baby's laying across, or is it oblique lie? And that's when the buttocks is coming out first, so a breech presentation. Okay, and you'll see this here. Okay, so the vertex is straight down. The military is where the baby's like chin up, and then the extension is where it's face first. Okay, so you just make sure you read through all of those. and that is called the cephalic presentation, vertex here, breech presentation. You know, of course, when it's the buttocks first, and this is 4.6 of births. Then you have frank, complete, and footling. So frank, this is on page 192. There's that picture. So here, frank is buttocks first, straight down, okay? Complete or full is where the baby's kind of crisscross, straight down. Footling is when a foot comes out first, and double footling is, of course, both feet coming out, okay? Shoulder presentation is where the shoulder, it's a transverse lie, like here, and the shoulder is coming out first, okay? So I want you to be familiar with this frank breech term, okay? Wink and lollipop, you need to know what frank breech is. The most common type of breech presentation is the frank breech. Alright, so we have station. So when we're giving report or charting about the presentation, station, dilatation, effacement, station is the level of the presenting part according to the ischial spine, which are here, these little places. And I'll show you this with the pelvis in class. The ischial spine represents the most narrow part of where the fetus has to pass through, okay? Wink and lollipop, you need to know that the ischial spine, when the baby's top of the baby's head is lying evenly across here, lined up with the ischial spine, that is considered a station 0. So 0 station. So you have the first number we give, like if I say she's 450 and minus 2, that means she's 4 centimeters dilated, she's 50% effaced, which means up here the thickness of this 50% is gone, so it's on, like this is a 0, okay, if it's all there. Thick is another term, like close, thick, and high. So 50% effaced, which means half of the cervix is thinned out. And then you have the station. So if I say she's minus 2, that means she's minus 2, she's above the ischial spine. So minus numbers go above it, plus numbers go below it. So minus 2 means she's minus 2, the fetus is minus 2 centimeters above the ischial spine, okay? 0 means they're lined up. So if I say she's plus 1, that means the fetus is plus 1, is 1 centimeter below the ischial spine, okay? Important, important, important. You need to know, wink and lollipop, what we lined up. So we line up the ischial spine as our landmark, and that identifies 0 station, okay? Position. So right, left, transverse or midline even, and then you have the landmarks that we talked about. So the mentum, remember, is what? The chin. The sacrum, of course, we know is what? The buttocks. And then acromion process. Anterior, posterior, transverse. Okay, so you see the picture of the station. So 0 station is when we line up. I know that other picture I was pointing here, but this is actually behind that area. And I'll show you on a real pelvis. But it's these little parts back here. That's the ischial spine, okay? Kind of lines up behind there. So this is 0 station. Plus 3 is 3 centimeters below this. Minus 3, 3 centimeters above this, okay? So So now you have the positions. So let's talk about the presentations. So right occiput anterior, we'll look at this in the book and do this together. That means you look at the mom's position. So this is her right side. So the right occiput, and the baby is facing, the fetus is facing anterior to the mom. Okay, so the front of the mom. Okay, so that's why the occiput, the right occiput anterior, is noted on this position. Right occiput posterior, so the occiput is posterior towards the mom's back and on the right side, so it's right occiput posterior. Okay, so let's look at this one. Right mentum posterior, so this mentum, which is the chin, is facing the posterior position of the mom on the right side. Okay, left mentum anterior, so this chin is to the mom's left. Remember, like we're standing right in front of her, and that's her. This is her left side. The mentum is the chin, and then it's the anterior part of the mom, so the front. We'll talk about this more in class. And there's the picture of the station again. All right, so let's talk about lightning. Lightning is when the baby, the fetus, drops. Okay, so the fetus drops. I know you've heard say, "Oh, girl, you dropped." That means we're talking about lightning. Okay, that's when the fetal head is settled down into the pelvis. The fetus is becoming ready to be born. Okay, they may experience some pressure, leg cramps, all the things that come with that fetus settling. Okay, all right, now a table that you need to know. This is a Wink and Lollipop, table 7-1. You need to know the difference between true labor versus false labor. Same chart over here. Okay, what is true labor? This is contractions that are in regular intervals. Contractions increase in frequency, duration, and intensity. The pain can be in the lower back, radiating around the abdomen. It's like pulling from the back around the flank area to the abdomen. Dilation and effacement are progressive. That means we're seeing changes. And then walking increases the pain. False labor, they're irregular. There's no real increase in the strength, the frequency, duration, and intensity. The pain is just in the abdominal region, which may indicate Braxton Hicks contractions. There's not really any cervical change, and the pain gets better with the walking. So a lot of times women will come to L&D wanting to know, telling us they're in labor. This is how we rule it out. We send them walking. You walking in the hall, is the pain getting better or worse? We check them when they get there, or is she 2 centimeters? After she's there for a few hours, we check her again. Is she still 2 centimeters? We put her on the monitor. Are the contractions regular? Are they irregular? This is how we rule out, okay? So I just mentioned Braxton Hicks. This is a sign of false labor, okay? There's no dilation change. There's no cervical change. There's those abdominal cramping or the growing even. And they can mistake that for true labor. Cervical change, cervical ripening is when we go from 0 to 10, okay? We may go from 2 to 4, and that's a sign of what? True labor. Bloody show, mucus plug. The plug that is in the cervix, up here, we should go back and show you. Right here, there's a little plug that sits here. And as this cervix starts changing, that mucus is discharged, okay? So you may have a woman come in and say, I lost my mucus plug. And a lot of times if the physician is trying to start labor, they will go in and kind of disturb that mucus plug area, and they will pass that. That does not mean that labor is imminent. They can lose their mucus plug or bloody show. They can 2, 3, 4 weeks ahead of time, okay? But sometimes, they can, but go straight into labor. But usually it's several days, okay? Rupture of membranes, okay? So we have what we call SROM and AROM, okay? SROM is spontaneous rupture of membranes. That means the water breaks on its own, okay? Then we have AROM, which is an amniotomy. This is artificial rupture of membranes, okay? That means the provider goes in and breaks the water. So SROM and AROM, you're going to see these on report sheets, okay? So just know the difference. All right. So another thing I want you to note is when the rupture of membranes happens, you need to note some things that happen when we see that water, okay? It's important to note the color, amount, and odor of the fluid, wink and lollipop, okay? You need to know the color. Is it clear? Is it green tinged? Yellow, brown tinged? Does it have flakes of meconium, which is a bowel movement from the fetus in utero? The amount. Is it a lot of fluid? Is it just a little trickle? And then does it have an odor? Okay? The odor can indicate infection. So we need to know what it looks like. There are oftentimes white specks, which is the vernix. That's the cheesy substance that protects the skin of the fetus in utero. Or you may even see some little bits of fetal hair. The lanugo is what it's called, and it's all over the baby's body, the fetus's body. And when the baby's born, fetus is delivered, you can see that, especially in certain ethnicities. Hispanics have a lot of lanugo. If the mom is post-dates, which after 40 weeks, sometimes they will have meconium, which means the fetus has had a bowel movement inside the amniotic fluid inside the womb. And this can be bad for the fetus's lungs, the baby's lungs. So I say fetus when they're still in utero, baby or newborn after they're born, okay? So you need to note all of these things. Occasionally they will have meconium passage before 40 weeks, but it's usually a post-date baby. All right. There's some more characteristics over here on a little chart that I found. Stays in the back, even in the belly but not radiating from the back to the belly. So you can just look at these. Alright, so let's talk about the amniotic fluid. Okay, so there's nitrazine or amnisure kits, which is a swab that we use. This is the nitrazine paper. Okay, so this is what 23 years ago when I started as a labor and delivery nurse, we used this right here. And then we used a microscope, and you'll still see it listed in the book. And this is on page 196 in the procedure. Actually 196. 197 actually too. So this is 196. This is talking about the pH on the nitrazine tape. And then you see the equipment, and it's listed here as well. So they have the amnisure tests now that are very popular, supposedly more accurate, and this paper will turn purple, a false reading if KY jelly or any type of lubricant is used. So if a patient comes in telling you that she thinks her water broke, do not use KY or jelly or any type of lubricant, because if you use the amnisure or the nitrazine, it can become a false positive. The best tool I think to use is the microscope. They're hard to find on units now, but the ferning pattern is indicative of amniotic fluid. Okay, so you go in, you get a sample, put it on a slide, a glass slide, and you look under it, the microscope, and you'll see this ferning pattern, and it truly looks like a fern leaf. Okay, So, does lubricant firm on a microscope? No, it does not. So that's why I'm saying this to me is the most accurate test. Alright, but they do use those Amnisure kits, and there's some more trade names for those little swabs. Okay, but you'll see this crystallized burning pattern on a microscope, and that indicates the amniotic fluid. Okay. Alright, so let's look for assessments. This is on page 199. Focused assessment, psychosocial assessment, and then we're going to talk about documentation. Okay, so Wink and Lollipop, it's very critical that you note all of this information when you are doing your head-to-toe assessment. Okay, and you can write some notes in your book if you want to out beside these. Gestational age. So if I say she's 38 and 5, that means she's 38 weeks and 5 days. Estimated date of delivery, that's her due date, right? Vaginal exam. So this is what this is right here. So what is her vaginal exam? So I would write vaginal exam out beside this one, okay? Remember, I'm saying like 250 and -1. So that means she's 2 centimeters, 50% effaced, and her station is at -1. And I would say and vertex. That means the fetus is head down, okay? FHR, fetal heart rate in response to contractions, and you can also put out here and contraction pattern, okay? And then another thing, ability to cope. So this is reporting any pain. So report any pain. So when you call the OB to give them report, you would say, you know, her pain is 5 of 10 on the pain scale. Do not report anything that's normal. So you're not going to say, well, her blood pressure is 120/80 and her hemoglobin is 13. You know, you don't want to report anything that's normal. Give them the abnormals, okay? So if her platelets are 100, they probably need to know that, right? So you want to report anything that's abnormal. And this, of course, is just the positions. We'll talk about this in just a second. On page 203, this is like a delivery record. Of course, we use EHRs, right? So everything is going to be on that. But these are some of the things that you chart. You can look at that in your book. It's on page 201 and 202. Now let's talk about the fetal position, auscultation of fetal heart tone. So where are we going to find the fetal heart rate on the mom's belly? Okay, so if the fetus is laying RSA, which is right, what? Sacrum anterior, that means what? The buttocks is facing up here, okay? ROP, so that's right occiput posterior, the back of the head is here. Right mentum anterior, the chin is here. Right occiput anterior, the back of the head is here. Okay? That's what those mean. Let's look at Leopold's maneuver. So let's go back up to 203. Right here. So Leopold's maneuver is when we try to move the fetus to a position that is ideal for delivering vaginally. Okay, we can get the accurate fetal position. We can, you know, if we can try to turn the baby, you do this with ultrasound and you do this with the OB. Okay, and they're trying to turn it. It's painful for the mom, but we try to turn and make sure the fetus is okay. You know, we're not pulling on a cord. We're turning the baby where she won't have to have a C-section. Okay. Assessment of fetal heart rate, we just talked about that, and then auscultation of the fetal heart sounds. Okay. And this picture is on page 204. so let's talk about the different monitoring devices for a mom. This is a long chapter, so it will probably be in 2 parts. We'll see how it goes. But 7 and 8 are long. So let's talk about the electronic fetal heart rate monitoring. Okay, there's 2 different kinds that we use. All right. So here is the external fetal monitor. Okay. So this is monitoring the TOCO, is what we call it, is monitoring the strength of the contractions from the outside on the mom, so externally. And then the ultrasound, the FHR, the monitor, is monitoring the heart rate on the outside. Okay? And then if we want to monitor the strength of contractions on the inside, we use an IUPC, intrauterine pressure catheter, and I'll show you this in class. The water has to be broke. Okay? You can't break the water just to put a monitor in, and I've seen nurses do this in the past. The only person that can break water is the provider. So you're a medical doctor, a DO, or a midwife. Okay? You can't just go in and break water as an RN, because bad things can happen. You can have a cord prolapse, fetal decels, it can be bad. Do not be liable for that. Do not do that, because it's out of your scope of practice. And then you also have a scalp electrode, and this actually, and I know this sounds horrible, but it's not really. It's just like a little tiny screw that screws into the baby's skin on the scalp. It's just like a finger prick for a glucometer check, glucose check. It doesn't hurt the baby. We just put a little Neosporin on the little cut on the head after the baby's born. Okay, triple antibiotic ointment. Okay, so if we can't pick up the heart rate well, we use the scalp electrode. If we can't pick up the contractions well, we use an IUPC. So these are reasons, like we're having hard time tracking the baby externally, tracking the fetal heart rates externally, having a hard time tracking the contraction pattern. So that's when we do this. There's more reasons that we use the IUPC we'll talk about in a little bit. Okay, so let's talk about fetal heart rate and various, and I'm giving you a packet when we get to class over some of these, okay? So baseline fetal heart rate. Let's look on page 206. This chart you can look at. So tachycardia. So our heart rate for our fetus needs to be between 110 and 160. Anything below 110 is bradycardia. Okay? Anything above 160 is considered tachycardia. Wink and lollipop, you need to know that. Okay? This is an example of a fetal heart strip. You see these dark red lines? That means there's 1 minute in between there. The small is 10 seconds, and it's 10 seconds above. So it's 90, 100, 110, and then 120. See that? But each one of these lines from here to here is 1 minute, 60 seconds. Each box is 10 seconds, up and across. So ideally, we want our fetal heart rate to stay between 110 and 160, okay? So you just kind of get the average of where the heart rate is. These are considered accelerations. This is what we want. We want a happy baby that kind of is excited, doing well, good oxygen perfusion. This is what we want, okay? The top part is our fetal heart rate. The bottom part is our contraction pattern. So these are contractions. And remember, we talked about frequency a while ago, right? So the frequency is from here all the way to here. That's from the beginning of one contraction to the beginning of another contraction. The duration is from the beginning of this contraction to the end of this contraction. Okay? So you see 1, 2 minutes. These are 2 minutes apart. The duration is 1 minute and 40 seconds. Okay, so 100 seconds is our duration of this contraction. Okay, so this is 2 minutes and 10 seconds or so is the frequency. So the frequency from here to here would be 1, 2, 3, 4. So her contractions, based on this little strip, are 2 to 4 minutes apart because we get the average. This one's 4 minutes apart, but this one is 2 minutes apart. So we say she's contracting every 2 to 4 minutes. Okay? All right. So let's talk about some bradycardia issues. Okay? So, wink and lollipop is this paragraph. Okay? You need to know all about these. What's going to happen? Okay? So, I'm going to give you a sheet of paper, this line pit, and we will talk about this, but and it stands for the things that you should do. So, if the fetus has a drop in their heart rate, which is called bradycardia or deceleration, we're going to turn off the Pitocin. We're going to place her on her left side. And our left lying side, why do you think we choose the left side versus the right? Well, because what is on the right side of our body? Our vena cavas, right? So we don't want any pressure lying on those main vessels. So we flip her to the left side to get her off of the vessels, okay? And that's better perfusion for the fetus, the placenta, okay? Scalp stimulation. This is when we go in and scratch the baby's head, scratch the fetus head to perform that scalp stimulation. Hopefully increases the heart rate on the fetus, okay? Vaginal exam, we're checking for any cord prolapse. That's when the umbilical cord comes out into the vaginal vault, okay? And hydration status. So we're going to increase fluids. We're going to give her that bolus of IV fluid to hopefully help make sure the fetus is sitting in a lot of fluid, because if her water's broke, they've lost that fluid, but we want to rehydrate her for that reason, okay? She's going to have an IV going anyway, but we're going to increase those fluids by giving her a bolus. And then we're going to place oxygen on her, okay? Fetal oxygenation, whatever the mama gets, the fetus gets. So we're giving her a non-rebreather mask, opening it wide open, 8 to 10 liters a minute. I just turn it and open it wide open if I got a fetus in distress, okay? So wink and lollipop, you need to know this. In my book, I have under hydration status, which is, can't see if we're looking for it. Here, fluid administration, hydration status right here. I have IV fluid bolus written beside that. So if you want to write IV fluid bolus. Alright, so let's go over here and look at these strips, okay? So variability. This is, and in the packet that I'll give you, we'll discuss this too. Variability. So absent variability. That means this fetus is asleep. Like nothing's going on. Probably mom maybe have gotten some Stadol, Phenergan, fentanyl, something for pain, Dilaudid. Minimal variability, just a little bit of variability, and this is also in your book on page 209. And then moderate variability, this is what we want. This is ideal, 6 to 25 beats a minute from the baseline, indicative of fetal well-being. And then marked, anything over 25 beats a minute from the baseline. Okay, so this is all over the place. This fetus is stressed, okay? So, absent is undetectable. Cerebral asphyxia warrants evaluation. We need to make sure this fetus is okay. Minimal 2 to 5 beats a minute. Something's going on, probably some pain medicine, either fetal maturity or the fetus is asleep. This is what we want, 6 to 25. And then over 25 is considered marked. This is just the packet that I'm going to give you in class. Early deceleration. So what is an early deceleration? This is when it's a mirrored pattern with the contraction. So you can see this here. They're considered benign, not really anything to worry about. Just watch and make sure everything's okay. I'll give you a sheet that's called Veal Chop as well. The V lines up with the C on chop, so the V in veal lines up with the C on chop. So that means variable is cord compression, and we'll go through that. The E, early, is head compression. So a lot of times with earlies, we'll see fetal descent. The baby, the fetus is coming down into the pelvic area, okay? And then the A is everything's okay, A-OK, with the O in chop. And then the L in veal is late decels, and it lines up with the P, which is placental insufficiency. So something's going on. They're not getting perfusion as they should, okay? So variables, and we'll look at this in the packet. On page 210, these are the monitors, of course, again, okay? This is the earlies where they are in line. The variables, kind of like a V pattern is the variables. Uniform, and this is a late because it's coming after the contraction. But I'll show you this in class. This is what to do. This is on page 210. Please be familiar with this chart. Variables usually are indicative of cord compression, like I said, and we want to correct that by laying on the side. So I have veal chop written across here, V-E-A-L-C-H-O-P. You need to know this chart, okay? Wink and lollipop. You need to know this chart. You need to know what happens, what do you need to do about it. You need to correct that cord compression, fetal oxygenation. So for veal chop, especially for cord compression or placental insufficiency, you're going to improve fetal oxygenation, okay? There's a good chance it may be a cord compression, cord prolapse even, and then what are you going to do? For late decels, this is the worst, okay? We never, ever, ever want late decels. It's the worst. We're doing all the things for the line pit, and I'll show you that. So this is the veal chop, okay? Variable lines up with cord compression. Early, head, acceleration, which means everything's okay. They're oxygenating well. We want acels, okay? And then late is placental or uterine insufficiency. And you can see this over here as well. So it's a type of decelerations that happen with the fetal heart rate. Prolonged decels. So this is not good at all. This is when a contraction happens, heart rate goes down for at least 2 minutes, okay? They're not coming back up. These are lates, or actually they said these are earlies, actually, because they are mirroring the contraction. So you see this heel lines up with this heel. So when they're mirrored, it's early, okay? Variables, this is on page 211 in your book. Variables look like a V, okay? So they are okay. You just need to watch them, all right? And then we have lates. Now the lates start at the peak of the contraction, okay? So this is how we tell the difference between an early, which mirrors it, right, and a late. So a late starts at the peak of the contraction. So you see how it starts going down when the contraction's all the way up. Okay, this is a late decel. Then we have a prolonged. You see how long it lasts? These are not good. This is probably when we're running to the back for a stat C-section. Okay, we don't want that because something is being compromised in our fetus. Okay, so this is a sheet I'm going to give you to line up, and then I have one that says line pit. So when you have decels that you don't like they don't look good on the monitor, you're going to do the line pit. That's left side. Increase the IV fluids, oxygenate, notify the MD, and turn your Pitocin off. Okay? I had a student tell me that he remembered this on boards. He had a question about what to do, and he remembered the line pit. He used it. So you may see a board question on your NCLEX that's regarding this. So please take note of veal chop and line pit. Okay? All right. This is again talking about the early decels, the late decels. Uncoil is another thing, just like line pit. Okay? And then a poison is another, a lot of acronyms in this little book. Alright, so let's go down here, different categories. So in your packet you have the category. Category 1 is good. Everything's fine. Baby looks good. Mama looks good. Category 2, we're a little concerned. What's going on? And category 3, we need to do something about it. Having lates and all the things. Okay? Let's go back up to lates right here. Alright. So, wink and lollipop, you need to know right here on page 212. With late decelerations, late onsets, it peaks at the contraction, right, at the peak of the contraction. This is utero-placental insufficiency, a decline in placental function. You need to know this right here, wink and lollipop, okay? And let's look at the fetal heart rate terms, okay? You need to know what category 3 is. We just talked about that. This is not good, okay? Sinusoidal pattern, recurrent lates, recurrent variables even, bradycardia. We want our heart rate to be on a fetus what? 110 to 160. So make sure you understand that, wink and lollipop, okay? Alright, I'm going to stop here and we'll finish this chapter up in part 2 of chapter 7.